Hi, everyone. Welcome to the fourth webinar in NASTAD's 2017 PrEP Financing and Access series. For today's webinar, we're going to cover strategies and considerations to engage clinical providers into delivering PrEP. Thank you for joining us. I'm Edwin Corbin Gutierrez, Senior Manager in the Health Systems Integration Team here at NASTAD, and I'm joined by my colleague Zach Rowe from the Prevention Team, also here at NASTAD. Before we jump into formal introductions and dive into the presentations, I want to cover some logistics and give you a little more information about the series. In terms of logistics, Dr. Krakover flagged a few articles for us as homework. You can access the articles and the recording for this webinar, as well as others in the series, through NASTAD's online technical assistance platform. The site is nastad.blackboard.com. If you haven't opened up an account yet, we will create one for everyone attending the webinar by the end of the day, and you can also email us at ontap@nastad.org. Your username will be the first letter of your first name and your last name. So for example, Jane Doe's username would be JDoe. Your default password is just password. And if you run into any trouble, again, please don't hesitate to email us at ontap@nastad.org. The archive of the webinar recording is also on the platform, and a few other materials are also on there, including PrEP insurance and financing navigation training curriculum that Colorado shared with us on last week's webinar. To contextualize today's conversation for our new participants, NASTAD's PrEP Financing and Access series showcases strategies that health departments and community health providers have developed to finance PrEP programs, decrease disparities in access to the intervention, and evaluate these programs. So far this year, we've discussed PrEP drug assistance programs in Washington and Illinois, specifically how to leverage their infrastructure and expertise from the ADAP program to facilitate access for PrEP, including strategies to make these programs easy to access for PrEP candidates and strategies to contain costs. We discussed PrEP directories and online navigation resources with pleaseprepme.org. In June, we featured Iowa's TelePrEP program, which brings together telemedicine and public health resources, and it leverages pharmacists' expertise to deliver PrEP in rural communities. And then last week, we reviewed Colorado's PrEP insurance and financing navigation training materials. Last year, we also covered a few topics. We talked about delivery models at federally qualified health centers in Louisiana and STD clinics in Virginia, including considerations regarding the 340B program. We also covered online PrEP provider directories with preplocator.org. We went over NASTAD's 2017 cost calculator for marketplace health plans, and we discussed New York and Utah's PrEP evaluation efforts, focusing on how to leverage claims data and other healthcare data sources. The archive, as I mentioned, is available on our online technical assistance platform. So with that, let's dive into provider engagement. We know from provider surveys that there is a need to increase provider knowledge about PrEP, and health departments have expressed an interest in engaging new cadres of healthcare providers for PrEP. In a recent survey that NASTAD conducted with state health departments to assess a range of core competencies, almost half indicated that provider engagement was an area of particular interest to them. In their comments, 21 states indicated that a major barrier for PrEP implementation was not having enough providers willing to prescribe it. So for today's discussion, we asked our presenters to discuss considerations when engaging clinical providers in prescribing PrEP and to share more about their lessons learned from their experiences designing, implementing, and evaluating these activities. Our first presenter today is Dr. Douglas Krakower, who is a member of the Division of Infectious Diseases at Beth Israel Deaconess Medical Center, a research scientist at the Fenway Institute, and an assistant professor in medicine and population medicine at Harvard Medical School. His research focuses on ways to optimize HIV prevention in care settings, and he is currently conducting NIH-funded studies to enhance patient-provider communication and clinical decision-making regarding the use of PrEP. His clinical practice encompasses general infectious diseases and HIV treatment and prevention. Our second presenter is Dr. Darpan Sachdev, who is a clinical prevention specialist in the Disease Prevention and Control Branch at the San Francisco Department of Public Health. She directs the citywide linkage, integration, navigation, and comprehensive services, LINKS, program and is the programmatic lead on data to care initiatives. She also directs public health detailing activities. And with that, I'm I just want to say I'm excited to have you both here joining us today. And Doug, I'll let you take it away. Thank you.
In PrEP, and let me advance the slides here. Here's some of my disclosures. So we'll talk about the current state of awareness and experience with PrEP among clinical providers, which is quite variable by specialty and also probably by region, and some considerations for how to increase the diffusion of medical knowledge about something as innovative and exciting as PrEP, but which may be new for a lot of clinical providers who aren't specialists. Also talk about ways that team-based care can facilitate PrEP provision in real-world care settings, and also some tools for clinical providers to make this as easy and straightforward as possible, which can maximize the likelihood that providers will become engaged and experienced with PrEP. So to start off about talking, this is how do we communicate knowledge about PrEP to providers in a way that's most effective. This first slide looks at a hypothetical provider cascade of care, which is just a theoretical framework to think about engagement of a community of providers. So if you think about all of the providers who are able to prescribe medications, some fraction of them, hopefully a high fraction, will be aware of the concept of PrEP, but maybe fewer will be willing to prescribe PrEP or think that PrEP is something that falls within their clinical purview, and then fewer will be fully trained and comfortable with prescribing PrEP, and then even fewer probably have real experience prescribing this as part of their practices. And then there's probably an even smaller number of people who are able to accomplish all of these steps in the cascade and also are fully competent to train their colleagues. And these may be sort of local champions, as a term that sometimes is applied, and they can ideally amplify some of the positive effects on increasing other aspects of the care cascade by being the voice of PrEP for their colleagues. And one point I'd like to make is I think that provider-to-provider communication among trusted colleagues is one of the most effective ways to try and engage new providers in something like PrEP. And we'll talk a little bit more about that as we go forward. So this is a framework of how medical knowledge is diffused through communities of providers. And it's from Jeffrey Moore's book, Crossing the Chasm. And this paradigm has been applied to many things in healthcare and also other aspects of how new technologies diffuse in communities. And the idea here is that when you have something new like PrEP, at first you have a small group of innovators and then a larger group of earlier adopters representing together about 15% of the total community of providers who kind of jump on board relatively quickly. They tend to be risk-taking in a sense in terms of their clinical practice and excited about trying out something new like PrEP. The challenge is to actually move across what people have termed the chasm, which is when you jump from that early adopter group to the larger majority of providers in the community. And there's an early majority and a late majority, and together they make up well over half of the total community of providers in this conceptual model. And the idea is that for the majority of providers, that they're not necessarily jumping on board early, you really have to make something innovative like PrEP a very safe choice, easy to do, not too complicated, not seem like something that is only done by people who have different training or specialized care models. And at some point, when they see enough of their colleagues who look and feel just like them, people that they trust and see as a reflection of their own type of practice, they will jump on board and follow the herd. Sounds a little bit pejorative, but the idea is that they don't want to be left behind what they think is a best practice. So if you can cross that chasm and engage the early majority, then the late majority tends to flip, and you've reached the tipping point when you can fully scale up something like PrEP. So it's a helpful conceptual model for how to diffuse PrEP in a community of providers. So where are we now in terms of awareness and experience with PrEP? These are some data from a national survey of HIV providers, the top group in red bars, and then primary care providers, the bottom group in blue bars. That was done in 10 metropolitan cities with high areas of HIV incidence. And they wanted to figure out what that kind of cascade of awareness and experience was among these two groups of providers. So HIV providers, to get to the punchline, were more engaged in terms of awareness and experience than generalists. You can see that almost all HIV providers had heard of PrEP, discussed PrEP with patients in the past year, and over half had prescribed PrEP. Whereas generalist primary care providers, fewer had heard of PrEP, many fewer had discussed PrEP, and only 17% had prescribed PrEP. So if you think back to that conceptual model, the diffusion of innovation model, it really almost exactly matches that early adopter innovator group where about 15% or so of people in the community have done this, and we need to figure out ways to make it as easy as possible for a majority of providers to get on board. as you think about engaging providers in something like PrEP, some other data from a national survey of primary care clinicians conducted by CDC 2 years ago shows that providers may have some preconceived notions on which types of patient populations they ought to be prescribing PrEP for. So in the survey, they found that providers, when asked, hypothetically, would be more willing to prescribe PrEP to a person in a partnership with someone with HIV as opposed to MSM, men who have sex with men, or PWID, people who inject drugs, or people with an STD. So the idea here is to think about, as we provide educational resources for providers, to really be robust in making sure they understand the full suite of clinical indications and populations who may benefit from PrEP, to try and not just increase overall PrEP utilization, but to combat disparities that can emerge if providers are making error-prone decisions about which patients may or may not benefit from PrEP. And so provider biases, either conscious or really subconscious, can play into some of these decisions. So we have to try and counteract that with educational resources. So in engaging providers about PrEP, some of the research we've done here in interviewing clinical providers, we found that initially a lot of providers are skeptical at the idea of PrEP, but as they become more aware, familiar, and experienced with it, that skepticism actually evolves into more of an optimism with PrEP. So these are qualitative data, and I'll read you a quote from an LGBTQ specialist at Fenway Health, which is a community health center in Massachusetts that provides HIV prevention and primary care services to sexual and gender minority populations, as well as to a general population of people in the community. And it's where I've done some of my research on this topic. And one provider there who is familiar with PrEP and experience said, I initially thought, wow, that, meaning PrEP, is a really expensive intervention compared to condoms or other behavioral types of modification, but it's tremendously evolved. It works really well when people take it, much better than any behavioral modification message has ever worked. It's safe, and it's definitely worth implementing. So we found this theme in talking to a lot of providers that they were first skeptical, but that evolved towards comfort and actually optimism. This is something that's really good for their patients. Looking at a similar population of generalists, actually right up the road at Beth Israel Deaconess Medical Center, which is an academic center where I practice, we asked some general primary care providers about their experience with PrEP. They shared the same initial skepticism if they were not as prepared, but there was another theme that generalists would be willing to learn more and engage in this, but they wanted it to be really efficient types of training. And this quote illustrates that. As a primary care provider, I hope that it's my job to do a range of things that are important for health maintenance and prevention. In my mind, it's not something that's amenable to referring to a specialist for HIV. It's a conversation that I would be willing and happy to do. I think it would just have to come up, and I would have to do it once or twice. I don't think I need a week-long CME course about it. It's safe, effective, clear-cut guidelines, sort of like Plan B. So the takeaway here is, as we think about how do we engage providers in terms of community-based efforts, I think making this efficient, straightforward, and succinct is going to fit with what generalists are hoping to get them engaged. So moving on a little bit towards other ways to facilitate engagement of providers, I think that team-based care, when resources allow, can be a really effective way to do this. And this is an example of how PrEP works at Fenway. Now, Fenway is a little bit different than the average clinical care center, as I mentioned, and they have now probably close to 2,000 people who have been prescribed PrEP. So the providers are very familiar. What they've done is they have a team-based structure where you have primary care providers, nurses, medical assistants, behavioral health specialists, given a lot of people who may have indications for or use PrEP have behavioral health conditions or substance abuse issues, team case managers, pharmacists, and even health system navigators or PrEP specialists. That's all part of a team of people who are aware of PrEP, understand some of the language, and are ready to support patients at any place they contact the healthcare team in learning more and engaging about PrEP. So this offloading and team-based approach can make it a lot easier for a busy clinician to engage in PrEP and to be excited about engaging in PrEP. So when resources allow, I think this is a good model, but of course, where resources don't allow, individual providers are absolutely able to do this on their own too with support. So the last section of the intro talk here, we'll talk about some of the tools that can facilitate PrEP use by clinical providers. And again, taking from the experience of Fenway, where essentially all the providers are familiar with PrEP, one of the things they did right away when PrEP was early on available was to come up with a very clear clinical protocol for the providers. And it's pretty succinct. This is an outline that fits basically on one page. And it's not comprehensive, but basically it goes through all the major points. And as I talked before about trying to make it as easy as possible for providers who may not be experienced in doing this, having an algorithmic approach, it may not be perfectly one size fits all, but not making providers reinvent the wheel and digging in to learn it all on their own, but having something that's structured, step-by-step, checklists, algorithms, outlines, can really make it easier for a generalist to adopt something new like PrEP. Looking at other tools, it can be challenging to identify in a large population which patients may be most likely to benefit from PrEP. So the CDC has produced a few tools that are risk screeners where either HIV testing specialists or clinical providers or anyone on the healthcare team really can administer brief questionnaires. This one is a 7-question battery for men who have sex with men to figure out if they would merit usual counseling and care around HIV prevention or more intensive interventions such as PrEP should be considered. So as you can see from the risk screener asks about sexual behaviors, drug-using behaviors, et cetera, things that have been validated to predict in some populations, although it's not perfect, whether someone may be a candidate for a more intensive conversation about PrEP. So finally, financial barriers are a consideration, and it's great to see NASTAD has excellent resources for addressing this as part of the larger series. We did a survey of the 32 Fenway primary care providers who had prescribed PrEP as of 2015. At that point, they had a median of 20 patients on PrEP each. So again, a unique place in that it's really a normative process to provide PrEP there. But about half the providers said they had at least one patient, if not more, who had encountered insurance barriers or copay challenges with getting access to PrEP. So I just want to highlight that there are assistance programs, and as we educate providers about PrEP, this is a common concern. How can people pay for this? So the educational resources would ideally have these resources about PrEP drug assistance and copay assistance embedded in the educational tools. So to conclude, one of the challenges is to have conversations between generalists who may not be experienced in PrEP and their patients who may not know a lot about PrEP either. And so part of the research we're doing funded by the NIH is coming up with quick tools that are online, which patients and providers can do during clinical encounters. And so this is just a screenshot of a tool we've created called Understanding PrEP, which we're still actually developing and testing, and hopefully will be available sometime in the next few months. But the idea here is, again, have tools where busy clinicians can jump right in, have a few easy step-by-step things to help them get going. So as a bridge to the second part of the conversation today with Dr. Sachdev, when we think about what providers want, to summarize, efficient, easy, succinct educational tools that are geared towards the types of information gaps they may have. And one of the most promising strategies we think for something like PrEP, which is a new type of procedure or innovation, is to use something called academic or public health detailing, also known as educational outreach visits, where information specialists from either public health departments or academic institutions can go to providers at their places of practice and engage them in highly interactive, individualized educational sessions about PrEP that are brief and don't take up too much of their time, but very efficient. So with a segue to Dr. Sachdev's talk, she'll talk a little bit more about this idea of academic or public health detailing. Thanks for your attention, and I'll be happy to answer questions soon.
Thank you so much, Doug and the team at NASTAD for the opportunity to speak today. As Edwin mentioned, my role is in the public health department here in San Francisco. And over the course of this past year, we've been really working toward trying to implement a public health detailing program that addresses the need to scale up PrEP, particularly amongst priority populations here in San Francisco. As many of you know, PrEP has really had a large uptake here in San Francisco, but that's been primarily among white gay men. And as part of a large grant from the CDC, Project Pride, we've been wanting to focus on increasing uptake among Black and Latino MSM as well as trans women. So yeah, so just to reiterate what Doug said about public health detailing, also known as academic detailing. It's a structured conversation with clinical providers, ideally face-to-face, in which a public health detailer or someone who's a clinically trained educator is providing evidence-based information in an unbiased way to clinical providers. As part of this intervention, we're often continuously conducting a needs assessment with the provider to understand sort of what their current clinical practices are, what might be some of the barriers to being willing to prescribe PrEP, and also tailor the education so that it feels relevant to the clinician's clinical practice. And during the process of detailing, we're often trying to ensure that we get some kind of commitment to change or modify one's practice. So there's a lot of checking back in with the provider to ensure that they're sort of following along and they see how some of the information could be integrated into their own practice. In terms of us learning how to do detailing, we have been partnering very closely with NARCAD, which is a Boston-based organization that Doug also works with. And you can get more information from them at the website that I've listed. But they, in partnership with establishing our program, they really were able to help us tailor our content, and they also provided us with a 2-day on-site workshop where we got to practice and learn sort of the tricks of the trade of detailing. So how do you start a detailing program? I think some of the big questions that we had to answer as we went through this past year is first deciding what are the clinical practices that we're trying to promote. Then we thought through what are key messages. We had to figure out who will develop the materials that we give to providers as well as patients, and then also who will conduct the detailing. The next thing we had to figure out is how are we going to identify providers to be detailed, and then also the monitoring and evaluation components of how we measure these outcomes, and then how do we maintain the relationships with the providers moving forward. In terms of us first starting off with sort of what are our key messages, we really wanted to, and we're really encouraged by NARCAD to ensure that the messages that we were trying to get across to providers were action-oriented. So where we landed was with 4 key messages, which I think most people would find familiar. The first one is to take a thorough sexual history to identify patients who could benefit from PrEP. Number 2 was to offer PrEP to patients identified as having risks for HIV. The third was to conduct an HIV test to confirm that the patient is negative before starting them on PrEP. And the fourth was to follow up with patients every 3 months for HIV and STD testing, as well as prescribe them with 90-day PrEP refills. So as you can see here, we tried to be as prescriptive as possible to make it easier for providers to start this process, especially given that many of the providers that we felt like we may interact with were either potentially in training or were probably not the early adopters, because many of the early adopters are sort of already prescribing a lot of PrEP, and we knew we were probably reaching some people who may have had more reservations or concerns or not been as familiar with antiretroviral prescribing practices. So in terms of the next step of developing the materials and hiring the right people, in San Francisco, we decided to hire a nurse practitioner to conduct our detailing. And also she was able to assist with the development of materials. As I mentioned, NARCAD came to San Francisco to help us with training, with sort of scenario-based training that was really helpful and allowed us to also hone our key messages and sort of the overall process in which we would move forward with detailing. Additionally, we worked with a graphic designer to tailor our materials and make them visually appealing. As we all know, sort of some of the materials that are already available have all the information, but they may be very dense and hard for a provider to be a part of. So as part of this strategy, we really wanted visual aids that we could leave with providers where they could quickly access information and be able to go back to key concepts that were discussed with the detailer. And then we also really work to not only develop provider-facing materials, but also some patient-facing materials, because if we were asking providers to prescribe PrEP, we also wanted to give them materials that they could provide to their patients on what PrEP was and how to take it correctly. And we thought that these aids would benefit both the providers and the patients, and encouraging best practices around PrEP use. I do want to mention that other jurisdictions have hired former sales representatives or professional pharmaceutical detailers to do this type of work. In San Francisco, we chose to hire a clinician because we felt like the providers here would be most responsive to a clinician interaction. And I think this also kind of reflects what Doug was talking about in terms of sort of the provider to provider discussions in being able to influence practices. We also knew that PrEP was going to just be one of the topics that we wanted to discuss with providers over time, and that it would be helpful to have a clinician to help develop other types of detailing programs over the course. So by having a nurse practitioner, we've been able to be really successful in broadening the topics so that we can keep up relationships with providers. So in terms of creating provider-facing materials, we like to call them swag. We developed a brochure in which we sort of had this logo called Ask About PrEP, which sort of was something that we then stamped on other materials throughout this detailing campaign. We also, within that brochure, we created a mnemonic, which for sexual history taking, which is PrEP and is listed there. But we decided that you know, the 5 Ps work for some people, but maybe having something new and catchy could get the attention of providers and help providers who weren't as comfortable with sexual history taking actually start implementing this practice. We also utilized a provider pocket card that has been developed here in San Francisco with other colleagues. And we placed all these materials in a little bag that had our logo on it. Next slide. So in our Ask About PrEP toolkit, the patient-facing material included a palm card and a poster. We found that several provider offices don't actually hang up posters anymore, but they are willing to give palm cards to patients as they're getting their vitals. So we've had some clinics that have been very interested in this material, and basically it's just asking patients to ask their doctors about PrEP. Additionally, there's a tearaway pad that has something called PrEP Basics, which summarizes just key points on PrEP education to ensure that patients know how to take PrEP and what to do if they miss a dose, and what to do if they want to stop PrEP. Just sort of the key aspects that we hope that the provider would be able to cover with a patient who's initiating PrEP. We also have versions of the PrEP Basics in Spanish, and a new version coming out specialized for trans women. And we also purchased these little water bottles and placed sort of our logo on them. And the water bottle has a little pill case, a 7-day pill case, that we thought would be a handy reminder of the fact that PrEP needs to be taken daily. So during the course of the visit, one of the key components is really getting commitment for practice change. And so as part of this, our detailer will sort of summarize what's been covered with the provider, and then ask them if they're willing to either use a PrEP mnemonic for sexual history taking, whether they're willing to offer PrEP or use PrEP Basics during the course of prescribing someone PrEP or suggesting PrEP for somebody. If they're willing to ensure that the patient's able to get a follow-up appointment every 3 months, and whether they're willing to also continue to screen their patients for STIs with extragenital swabs. And then finally, if they're willing to provide the swag for patients at the time of a PrEP start. All of these we feel like are just sort of simple actions that can be discussed with providers, and if they're willing to do one, we think that that's definitely a step in the right direction and can be a point to follow up with them in the future. So how do you identify the right providers for detailing? And Doug did a really nice job of sort of summarizing all the different kinds of providers and what their potential responses could be to PrEP. We decided that we wanted to find providers that were serving our priority populations, and have been reaching out to places like student health, youth clinics, safety net clinics. We also have been willing to detail with small groups of clinical providers instead of sort of just a one-on-one interaction. And sometimes we find that this is really productive because it lets people sort of share their own practices around sexual history taking or PrEP prescribing. And I think, again, that sort of clinician to clinician discussion helps to build PrEP as a norm. In addition, we offer sort of just-in-time training. As our detailing program is very interlaced with my other work, which is providing partner services in HIV care linkage to all newly diagnosed patients. So when we find out that a patient has been recently diagnosed by a clinical provider in the community, we'll reach out to that provider to offer them detailing on PrEP, as well as some of the other initiatives going on in San Francisco, like early initiation of antiretrovirals. So sometimes we find that during that time period, right after a clinician may have diagnosed someone with HIV, it may be a time to grab them and ask them if they're willing to consider prescribing PrEP. We also do use some surveillance data, which I've called data to PrEP detailing, in order to understand who's diagnosed STDs or HIV in San Francisco in the last 3 years. And based on that list, we've reached out to providers who we think may be serving populations that may be at risk. And we've also gone out to people who we know are prescribing PrEP, because the whole high volume prescribers are also important, because they're really essential to ensuring retention in PrEP care, and that patients are getting routine STD screening every 3 months as recommended by us here in San Francisco. So as you can see, there's a lot of different types of providers to detail, and the focus can sometimes be different based on the type of provider. And I think that's where having a nurse practitioner is really helpful to do the detailing, because she can really tailor the package for what that provider needs. So some of the data elements we had to figure out in order to monitor what we were doing, we developed an evaluation. So this is a quick survey filled out by the providers. It takes less than 5 minutes, and it's prior to the discussion with the detailer. And then we have a follow-up survey, which should be completed anytime after 3 months after the initial detailing visit. All of these evaluations get entered into a database, which is an Access database that was created by one of our epidemiologists. And then we have a quality assurance plan in terms of to ensure appropriate data entry and analysis. Some of the other data elements that we developed included a map of all of the HIV diagnosing providers that had been generated by surveillance, because we felt that if the detailer was kind of already out in the field, then she could maybe drop by some offices that may be co-located with a person that she had already scheduled detailing. In addition, we had to figure out how to monitor contact attempts to providers. We typically schedule our visits. We don't just drop by in providers' offices unless it's been difficult to establish connection with them. So in doing so, we really need to make sure that we sort of pick up where we left off. Oftentimes a provider will say, well, can you get back to me in August or a few months from now when I've fully hired staff. And that is a really important thing, to be able to sort of maintain those relationships and ensure that we're following up with the providers as they've requested. And then we also, as part of our detailing package, offer practice training, so to frontline staff and medical assistants who may be part of the process of educating patients on what PrEP is. And for those individuals, we've created a separate evaluation known as the practice training evaluation. So here are some of our results thus far. This was run back in March, but summarizes data from 134 providers who had been detailed up to that point. And basically, the y-axis is all providers who had been detailed. The blue shows the number that had said that they had prescribed within that group, and the red is those who had never prescribed. So what you're seeing is that among medical MDs who we had detailed, about half of them had prescribed. People who said that they were not a primary care provider, very few of them had prescribed. People who said that they were not an HIV provider, again, very few had provided. Similar to what Doug had already mentioned, HIV providers, the majority had already prescribed. We also had asked questions about whether people had prescribed PrEP previously, and you can see many of the people who had prescribed PrEP had also prescribed PrEP. And we asked some questions about clinical, about characteristics of their practice and how often they conduct sexual history taking, how often they ask about anal sex among men who have MSM clients, and then also how often they're testing patients for extragenital STDs with a rectal swab. So these were questions that we wanted to include because we think that these are related to best practices around sexual health care. And you can see that providers who routinely do these practices were also generally, the majority had prescribed PrEP. So as I had mentioned, one of our key outcomes was also to evaluate whether providers were prescribing to priority populations as part of PRIDE, the grant. And while 39% of our providers had prescribed PrEP overall, that was 52 out of the 134, there was a lower percentage who had prescribed to patients within the priority population. So we're going to continue to monitor this value over time when we go and follow up with providers. So some of the challenges we found over the course of implementing this project is that it can be difficult to get time from providers. Sometimes using all staff sessions can be useful. Other times, and we've been less successful with this, is trying to get the clinic to carve out like a patient a time that a clinical provider would typically be seeing patients to actually do detailing. And sometimes we just have to do this during free time or lunchtime. Cold calls sometimes are necessary because of the lack of response to scheduled detailing visits. We also have been challenged by how to engage providers who don't really feel like their population would benefit. In addition, we've been really trying to focus on how to just improve overall sexual health care within clinical settings and routine STD testing within clinical settings. Another challenge is administering the evaluation, making sure that it gets completed. And then also trying to figure out how do we schedule follow-up visits so that we can get data that measures our primary outcomes. So one of the main things that we've been working on subsequent to developing our PrEP materials is sort of the next waves of detailing. And I think that this is really important to keep providers interested in the work that we're doing as a public health department. So as many people may know, San Francisco as a jurisdiction is trying to get to 0 new HIV infections. And sort of within that umbrella, we've created other detailing packages. One is focused on rapid initiation of antiretrovirals after HIV diagnosis, and you can see there's a nice detailing brochure that's been created for that. Another brochure has been created to increase retention in HIV care through HIV navigation. And then finally, we're in the midst of developing a brochure to improve sexual health care and try to increase routine STD screening. And we're planning, as part of our follow-up evaluations, to go back to providers and clinics and offer the STD piece, because we know that once a clinician starts prescribing PrEP, the next thing that they need to make sure to do routinely is STD screening, and that can often be more difficult in some settings. So I think I've covered the bases here, and I'm happy to talk to people and answer questions, whether within this webinar or later. Next slide. And I just wanted to give a plug for a Public Health Detailing Institute that's being offered here in San Francisco. This institute is being conducted in partnership with NARCAD, who will be on site to, I think, provide a similar training that we received in San Francisco when we first started our activities. You can get more information from Gary. You can see his email at the bottom of the slide. All right, and that was my last slide. So I'll hand it back over to Edwin. Thank you.
Thank you. Thank you so much. Great. We have just a few minutes, 7-8 minutes for questions. So with that, let's dive in. We have a couple of questions about the specific tools that the two of you mentioned. The first one is in relation to key populations. To what extent do the tools that providers are using, to what extent do they need to be tailored for a particular population? And specifically, are there any that speak to women's needs around PrEP?
I think as part of developing our patient basics, which is this one-page educational informational sheet, we have developed versions in Spanish and a version for trans women that's almost completed. I think we have not developed a version that's tailored specifically to cis women, and I think that while we do want to sort of have efforts moving forward that do that. Our STD detailing package does include a whole section focused on women, particularly because we're seeing increasing cases of congenital syphilis here in California, and we have very high rates of chlamydia in young women under 25. But that's a little bit different than sort of PrEP scale up among cis women.
Do you have any recommendations for kind of tools that would be effective with providers during an appointment with a patient, or are the decision-making tools that you're developing or have developed more focused on kind of imparting that knowledge in the provider before they see the patient?
You know, it's a very important question, because I think having very easy tools that providers can pull up on a dime, use on the spot, and kind of get from A to Z is very important, which is the goal of the one that we're still developing. And I think that there are other resources out there, sort of checklists for providers. There are online educational resources, stuff from CDC, also things like Up to Date Online, which is an educational resource. Lots of different ways for providers to get that information. For a tool that's meant to be done with the patients, that's something that we were exploring in that slide I showed. It's a little bit different because it's kind of a pair. We call it a dyad, a clinician and a patient going through it together. But you know, we'll see if hopefully that can make it a little bit easier. Until tools like that are kind of validated and available, then relying on the more classic instructional tools for providers are probably what's available. And also, to speak to the last question, I think it's a really great question about adapting tools for cisgender women. It's a very important population, and our intention was to start with a tool for MSM, given the epidemiology of HIV, and just trying to start relatively small and make sure we get things right. But absolutely the goal would be, just like Darpin said about educational resources that they've used, to expand it to different languages, populations, including cisgender women.
One question about kind of the diffusion of innovations model and the differences in attitudes and beliefs for those who are not buying into the model, and kind of are there specific needs to providers with negative attitudes about HIV, or is there a relationship there, I guess, between those negative beliefs and the kind of issues that need to be addressed in these trainings?
I think so. I think that there are potentially some differences. One would be addressing HIV-related stigma in healthcare, because there have been studies showing that healthcare professionals may have HIV-related stigma in some cases. So, and there are interventions developed to try and reduce that stigma. So incorporating that may be important. Addressing hypothetical concerns that providers have. Providers have wondered about the safety of PrEP, so providing them with clear evidence that's trustworthy from clinical studies and from the published literature that they trust is really important. Providers have wondered about will people increase their sexual risk behaviors while using PrEP and abandon condom use? What impact will that have on the protective effects in terms of HIV acquisition and also other sexually transmitted infections? So there's a whole series of concerns that are very understandable concerns for someone who's not as experienced with this. And so I think being very transparent and looking at both the pros and cons of PrEP. It's not a panacea, it's not perfect, and we really want to make sure we don't try and sell people something that's not fully accurate and tell them the good and the bad. And I think that with that honest approach and having it delivered by trustworthy people, either detailers like Alison Decker in San Francisco, who's could be a trusted colleague, or others, is a good way to convey that balanced information. That's the hallmark of trustworthy evidence-based medicine.
Yeah, and I think in San Francisco, because there has been such a rapid scale up of PrEP, and I think most providers are probably aware of it, you know, we've been really trying to focus on the quality of PrEP care and ensuring routine STD screening is done. And you know, at times we do have to sort of answer the question around, you know, are STDs increasing in the setting because of PrEP, and being able to really answer that in the appropriately nuanced way is essential. But I think it allows us sort of on the public health side to emphasize the importance of routine screening, STD screening, and the importance of just routine sexual history taking as good ways of doing primary care.
Thank you. In addition to the surveys, or maybe this is part of the surveys, are there any tools to assess these attitudes in providers, and how does that inform kind of how you tailor the interventions to assess negative attitudes? I
think for us, we sort of just start by, you know, again, asking the provider sort of what if they've heard of PrEP, have they, you know, and what are their practices around sexual history taking. This is covered in the evaluation that they're filling out prior to Alison speaking with them. But, you know, sort of getting an understanding of how often they're discussing sex within the conversations with patients currently, how often they're asking about rectal sex, how often they're asking about STD testing and performing extragenital STD testing, for us often gives a good picture of sort of how competent a provider is around sexual health care. And then that provides a starting place of how to tailor the detailing.
Got it, thank you. One question about evaluation. Are you able to collect data from the sites that you do detailing in and assess their prescribing habits? So for example, if there is a difference in the scripts written before and after the detailing activities?
We currently can't do that, but we hope to potentially down the road be able to do something like that. But it's difficult to imply causation necessarily, directly based off of a detailing visit. I think it's an important piece of PrEP scale up, but it's definitely not the only piece, because as this group knows well, PrEP navigators are so essential in continuing to promote the importance of PrEP and help people have access to PrEP over the long term. I hope that we'll continue to move toward the quality of PrEP care, and potentially be able to monitor some quality metrics like routine HIV and STD testing among a provider's patient panel who's on PrEP, and that would be a way to measure some of the direct effects that detailing has.
One thing I would add to that is sort of the ideal world is you would be able to have an objective measure of the impact using routine electronic health records data in places that have EHRs. So if you have a system where all the routine care is documented in electronic fields, then you can look in a very granular way at on a timeline what kinds of patterns of care you might see before and after detailing interventions at the level of an individual provider, for particular patient populations, for health centers, by zip code, sort of you name it. So that's something that is, in the ideal world, something that would be an available tool for monitoring too.
Thank you. That is something definitely that NASTAD is interested in exploring. If this is an area of interest, please stay in contact. The next question is about adherence support. Kind of after, a lot of the work in engaging providers is really about uptake. But I was wondering if there are any specific recommendations to addressing suboptimal retention and adherence for candidates that are already in PrEP, and whether those activities would follow the same infrastructure that's been set up for engagement around uptake, or would that look very different?
I think it's going to have some of the elements could be the same. So, for example, Darpin was saying for providers who are more familiar with PrEP and maybe prescribing it more regularly, you can tailor the educational approach to nuanced, advanced topics like STI screening. And the same thing would be true of, I think, ways to invoke best practices around adherence support. So detailing is really nice in that way that you can individualize it for the individual clinician's needs and stage of development with PrEP. And so I think they're the same sort of mechanisms can be tailored for that stage of PrEP implementation. On the other hand, I think coming up with innovative approaches that are not exactly the same are going to be important too, and maybe even borrowing from, as Darpin's other hat that she wears, retention and care for people who are living with HIV, population health management approaches, ways to do outreach to maximize retention and care. I think that there's a potential to learn a lot from HIV treatment and other areas of medicine where population health management to maximize retention and adherence are utilized, and to adapt those to PrEP. So I think increasingly that will be important.
Perfect, thank you. One question about sustainability. Could you speak a little bit about the funding streams or how existing resources can be maximized for an intervention or a set of interventions? Like, are there any tactics to implement this on a shoestring?
I think that is a conundrum because this has taken, for us at least, a lot of staff resources to create materials and to identify providers and develop a database, and then continue to sort of evaluate and monitor what we've done. And I think that it's hard to imagine just being able to just do this on a shoestring, but I think it has emphasized to me the importance of a health department having close relationships with clinical providers and clinical facilities, so that there's just sort of an ongoing dialogue over time, and that providers are not surprised when the health department sort of has something new that they want to talk about, and that we kind of know the people to get in touch with, and we also know the formats to offer that information, whether it's a large group all staff meeting, or whether it would best be done by bringing lunch to a small private clinical practice that's scheduled in advance, or whether it's a cold call visit to a provider. I mean, I think for us, we've just learned a lot about the different kinds of care that people are getting here in San Francisco, and learn more about how to interact with those providers. And if we were sort of better set up to be able to do that in the future, then we could more quickly disseminate information.
Thank you. Thank you. Thank you. I think, that comes back to the importance of building those relationships with providers that you mentioned earlier. We are going to wrap it up here. Thank you both for your willingness to jump in and share your experiences and your insight to guide health departments in their implementation of programs like these. We hope that it's been a helpful webinar for all of our participants. We'll have the materials available for everyone online. If there are any other materials that you would like to share with others, please feel free to send them to us at prep@nastad.org. And we will see you here for the next webinar. Thanks again to our 2 presenters and to everyone for joining us today. Have a good day.